This lecture will discuss advanced airway management and ventilation. One of the gold standards of being a competent paramedic is being able to establish and maintain a patent airway on your patient. The human body needs oxygen. The only way it's going to get it is through the airway down to the alveoli and into circulation. No other method. And we need oxygen. The brain has a 4-minute supply. So this is a constant patency of airway that we have to maintain. Without oxygenation, vital organs will not be able to undergo aerobic metabolism, and as a result, they will begin to die off. Anaerobic is only a bridge until aerobic metabolism can be reestablished. So the inability to maintain and manage an airway is the leading cause of death in the pre-hospital setting. So we need to understand the importance of early detection, rapid intervention, quick decision making, and once we've established the airway, continual reassessment. So we start with BLS. Paramedics are masters of BLS. Open the airway manually, recognize if there are and treat if there are any obstructions. Oxygen always plays into airway management, but use your oxygen in moderation. So do an anatomy review of the respiratory system. There are structural components and then there are functional components. The structural are in place to create that negative pressure inside the thorax that will allow air to enter. Under atmospheric laws, nature abhors a vacuum. So the creation of this partial vacuum of space through inhalation, the expansion of the chest, allows air to enter passively. This is why inhalation is considered to be a passive process. And there are different structures in place to allow for this passive process of chest expansion to take place. So you can see the upper airway is the entry point, and it's comprised of the nasopharynx, the oropharynx, and it ends at the larynx. Larynx separates the upper airway from the lower airway. The lower airway begins at the trachea, splits at the carina, goes down the bronchus to the bronchioles. Bronchioles are the smooth muscle that are able to constrict or dilate and regulate airflow to the functional portion of the lungs, which are the alveoli. In addition to breathing, the upper airway has structures that allow for chewing or mastication, being able to start the entry point for the GI system. There is a challenge with this because now we end up with two pipes. We've got our trachea anteriorly and we have our esophagus posterior. We know that we have a protective covering called the epiglottis that hangs off the base of the tongue that during the act of swallowing covers the glottic opening and forces the food down into the esophagus. This epiglottis is what needs to be manipulated in order for us to establish advanced airway maneuvers. So the nasopharynx is divided into two passages, and there are different openings known as sinuses that extend the airway. It allows for turbulent flow, and what that does when you breathe in through your nose, that turbulent flow warms the air and it also filters out the air. if you think about issues with the oropharynx, fracture can result in aspiration. You're not actually swallowing, so that the epiglottis may be out of play. So it could be more of drainage going down, which can cause that aspiration. The most common form of airway obstruction in an unconscious patient has been and always will be the tongue. Now we have, inside the mouth, we have our hard and soft palates, and really the palate, the hard palate, separates our oropharynx from our nasopharynx. You can see on that picture there, where our hard palate up top separates the oropharynx from the naso. Soft palate of your tongue, and you see how it connects to the epiglottis. Now, moving down to the larynx, this is where the upper airway ends and the lower airway begins. Once again, at the larynx is where the upper airway ends and the lower airway begins. Going down the trachea are formed by tracheal rings, and there's cartilage in between these tracheal rings. The thyroid cartilage is the most prominent in the trachea. In men, it's more prominent than women. Men, it's known as the Adam's apple. Right below that is the cricothyroid membrane. The cricothyroid membrane is a connective tissue, a ligament that actually is an easy access point for surgical airways. It's your marking point for a surgical advanced airway. If you look at the glottis under gross anatomy, what you're seeing right up front are the false vocal cords. Behind them are the true vocal cords. Now, looking at this picture, we're looking at a percentage of glottic opening, or a POGO score, of 100%. Wide open, you can actually see the trachea, the epiglottis is completely out of the picture, and you have a full view of the glottic opening. Different patients will have different POGO scores, as it were, and they could rate as a 70 or 60. Anything below 50 is considered a difficult airway. Now, the space between the epiglottis and the soft tissue is a space known as the vallecula. This is a landmark for endotracheal intubation. When using a Macintosh blade, that curved blade, it actually goes into the vallecula, as opposed to the Miller blade, which rests underneath the epiglottis and lifts the epiglottis itself. Some incorrect intubation will, instead of going through the glottic opening, instead go through little pockets known as the piriform fossae, and that can lead to a traumatic intubation. It's lining around the glottic opening, and can actually, the tube can accidentally be directed in there. A laryngospasm is a closure of the vocal cords, the false vocal cords up top, and a laryngospasm will actually seal off the airway. And an example of a laryngospasm is encountered during a near drowning event. Moving past the glottic opening, we're now traveling down the trachea. Trachea is that structural pathway for air to reach the base of the lung, the functional unit of the lung. So it splits at the carina into the right and left main stem bronchi. In addition to being a structural pathway, it also serves as a filter. It's lined with cilia cells up top towards the epiglottis, and these are cells that have hair fibrils coming off of them, and they trap particles that are inhaled in air. And then below that are goblet cells. These are mucus-producing cells. Down the bronchi to the bronchioles, now we start seeing the beta-2 adrenergic receptors on the smooth muscle of the bronchioles that when activated by albuterol or epinephrine, trigger a creation of a protein that instructs the cell to relax. So the smooth muscle, by relaxation, will dilate. Moving into the actual functional area of the lungs, we have the alveoli. Now, the alveoli is where the gas exchange takes place. It is taking place through that process known as diffusion, where particles from an area of high concentration move to an area of low concentration. The alveoli are staying open and allowing air to trap inside of it through the lining of surfactant fluid. Lines the inside of the alveoli. So when you're managing the airway, listening to lung sounds, you can use your sternum as your landmarks. So that's the process, the structure that gets air down to the alveoli. Once in the alveoli, through the process of diffusion, oxygen will cross over into the capillary beds, for the simple fact that there's very little oxygen coming back into the lungs from the right side of the heart. It's carrying deoxygenated blood. Through diffusion, oxygen will carry across. And inversely, through diffusion, carbon dioxide will carry across into the alveoli. So that's the process of gas exchange. It's all with the goal of eventual delivery to the cells. At this part, in the alveoli, this is where red blood cells and the hemoglobin that resides in the red blood cells will seat 4 oxygen molecules each and start the journey down to the left atria, through the left ventricle, and out to deliver to the body. So it's a combination of respiratory and cardiovascular centers working together to deliver oxygen to the cells in the tissue across the body. In addition to delivering the oxygen at the tissue level, through diffusion, once again, area of high concentration to an area of low concentration. High concentration being the capillary beds are now rich with oxygen at the tissue level, carrying across to the tissue, which has a lower level of oxygen, going into the cells using oxygen and pyruvic acid through the Krebs cycle to create 32 molecules of ATP, which is the battery pack of the cell. That's how the cells actually stay alive. And that Krebs cycle, waste product of this aerobic metabolism, is carbon dioxide. So the carbon dioxide is released by the cell and it diffuses across into the capillaries, ready for its journey up the venous system, back up to the lungs, so it can be excreted. That's the process of ventilation, the process of getting air into the body, and respiration, the process of the cells using oxygen to create energy and wasting CO2. That's known as cellular respiration. For ventilation, there are 2 phases. We have our inhalation and our expiration. We need to have both working efficiently because we need to take in oxygen and we, more importantly, need to exude waste. The drive to breathe is based on high levels of CO2 in the blood and cerebrospinal fluid. Inhalation is the muscular part of breathing. Understand, with atmospheric laws, one important law to take from is something known as Boyle's law. Boyle's law says the pressure of gas is inversely proportional to its volume. As the volume expands, the pressure drops. Under this law, this allows air to enter passively. It's not a sucking in of air, it's more like an expansion of the lungs, allowing air to go in. Because of the decreased pressure and increased volume. The diaphragm is the controlling muscle that starts the process of expansion of the chest. The diaphragm is a very interesting organ. It's actually both voluntary and involuntary. You can control your breathing, or you can choose to let it go autonomic. It really is one of the few muscles that you have that is voluntary and involuntary. Lungs have no true muscles. They actually, the structure, the only muscle that you find is the smooth muscle of the bronchioles, but the structure of the lungs is more connective tissue. So it relies on the muscles of the thorax and the diaphragm and the intercostal muscles to create this negative pressure field. So during inhalation, the thoracic cage expands. We end up with this negative pressure, air rushing in. And when do we stop the inhalation process? When the pressures are equalized. So you can see on picture form, the diaphragm contracts downward, the lung fields expand. The diaphragm relaxes and the lung fields tighten. So like I said earlier, diffusion is the process of getting oxygen across into the capillaries. It's also the law that has CO2 go from the capillaries into the alveoli. Liquid that contains gas has a volume, and what we've got is blood containing gases. This liquid, the plasma of blood, has to have a certain pressure, and Henry's law governs exactly what that pressure is. That pressure is the amount of gas you can dissolve in liquid, and it's measured in millimeters of mercury, otherwise known as torr pressure. This is important for capnography because this is what we're measuring. It's not percentage of CO2, it's torr pressure of CO2. You can only fill a container with so much of anything. So the container of the cardiovascular system is predominantly filled with nitrogen. Almost 70%, or about 500, 550 torr, is nitrogen. After that, the remaining space can be filled by oxygen and carbon dioxide, and the two gases compete for this space. This is known as partial pressure. If there's too much oxygen and it's completely filling the container, there won't be enough space for CO2 to enter. And inversely, if there's too much CO2 that's not being allowed out of the container, oxygen has no way to get in. So it won't even get in through the process of diffusion. In order for diffusion to work, you have to have adequate space for it to diffuse into. So what we're looking at, you say that deoxygenated arterial blood from the heart has a partial pressure of oxygen that's lower than the partial pressure of oxygen in the alveoli. What we're trying to do is normalize the pressure, allow for the space to be consistent. normal partial pressures in the blood should be, this is arterial blood, should be 80 to 100 torr of oxygen and 35 to 45 torr of carbon dioxide. So that's normal partial pressures. And they give ranges because things change physiologically, exercise, disease processes, all these things we don't have a fine score, we have a range, an accepted range. So 80 to 100 torr of oxygen is accepted, as well as 35 to 45 torr of CO2. Remember that the drive to breathe is based on elevated levels of this CO2 partial pressure in not only the blood, but the cerebrospinal fluid. And the apneustic center of the brain, the midbrain, actually regulates this. It monitors. When the partial pressure reaches a certain point, CO2 partial pressure, it triggers a breath. So that's your drive to breathe. Now, there are different things that can cause CO2 production. We have our cellular metabolism, but if the cells are actually under stress, either exercising or whatnot, then we will increase our breathing. Why? Because we increase our CO2 production through that aerobic metabolism. So the CO2 levels will go up faster, which will trigger a much faster respiratory rate. In addition to the increased rate, we'll end up with an increased volume. This is known as tidal volume. Every time you take a breath, the amount of air that goes in is known as your tidal volume. In adults, it's about 5 to 7 cc's per kilo. In children, we're talking about a little bit higher, 6 to 8 cc's per kilo. Like I said earlier, this is the structural area, the trachea, bronchus. They have no real function. So when you take a breath, air goes in, only a certain amount reaches the alveoli. The rest gets stuck in the bronchus and the trachea. This is known as dead space volume. The amount of air that's moved in 1 minute of tidal volume breath is known as our minute volume. And then we have our alveolar minute volume. It's the air that reaches the alveoli each minute. Once again, it's a lot less than what is actually taken in. So if you're a 100-kilogram patient is breathing at a rate of 20 breaths per minute, the tidal volume at 5 cc's per kilo, every time this patient takes a breath, they're inhaling 500 cc's of air. The minute volume at 20 breaths a minute, well, let's say, 20 breaths a minute is 10,000 cc's of air, but that's not all usable air. That's the minute volume, but it's not the alveolar minute volume. Now, like a balloon, there has to be structure, and you can never totally deflate a balloon. So you're going to end up with reserve. There's different types of reserve volume. There's the inspiratory reserve volume, okay, what's the additional to the normal tidal volume. And then we have our functional reserve that allows the lungs to stay open. Coupled with that is our expiratory reserve volume. That's the amount of air that's actually exhaled. So you inhale a certain amount, you exhale a certain amount, and there's always something left over to maintain the structure. Residual volume is the air that remains after maximal exhalation. And there's tests that you can give patients to see what their residual volume of air is by forcefully blowing. all this works into what's known as our total lung capacity. It's the ability to keep the airway structures open. Now the process of exhalation is passive, and it's forcing air out. So all the muscles are relaxing. The way exhalation works is through a negative feedback loop known as the Herring-Brewer reflex. So when you take a breath, once you've reached that level that's appropriate, the apneustic center triggers this negative feedback loop that causes the muscles to relax. So it's all monitored by the apneustic center in the brain and regulated by levels of CO2 in the blood. And how does it regulate those levels of CO2 in the blood? By looking at the pH of the cerebrospinal fluid. It's not a number, it's a pH. We want to maintain our normal pH at 7.35 to 7.45. You have a slight change in that, become a little more acidotic, it will trigger a breath. This is all part of the respiratory buffer system. This is what balances us. So the drive to breathe, by monitoring levels of CO2, is also, this is how it measures the pH level. So the drive to breathe, in short, is based on what your pH balance is. And if you become a little more acidotic, that's the drive to breathe. That's the buffer system to maintain homeostasis. Inversely, rising oxygen levels will suspend breathing, because rising oxygen levels means more alkalosis. So our drive to breathe is really a neural control. It's part of our midbrain, the apneustic center. It's the diagnostic center of the brain that your cerebrum, where you reside, doesn't really take into account. It's just part of daily living. The medulla controls your rate, the depth of breathing, the rhythm. It interacts with the pons and the apneustic center. And the apneustic center is there as your fail-safe. This monitoring of blood to cerebrospinal fluid is done through chemoreceptors. They're the ones that send the chemical signal to the brain for processing. So here the picture on the bottom, you're looking at the pneumotaxic center and the apneustic center sitting in the midbrain, and how it actually controls the phrenic nerve, the autonomic nervous system, to regulate breathing based upon pH. More acidotic, more breathing. Less acidotic, more alkalotic, less breathing. That's the respiratory buffer system. You can see these chemoreceptors monitoring carbon dioxide levels in arterial blood, and the central chemoreceptors monitor the pH of the cerebrospinal fluid. And that's your drive to breathe. There is a backup system in place at the aortic arch. dorsal group, this initiates the inspiration, triggered by messages sent by the chemoreceptors. The ventral group works in conjunction with the dorsal group to cause the muscular function to occur and inspiration to happen. So there are backups to the backups. The bottom line is you are constantly monitoring CO2 levels in the blood, pH of the cerebrospinal fluid in an effort to maintain balance and homeostasis. The last failsafe we have is a hypothetical failsafe known as the hypoxic drive. This is more in the central nervous system, and it's not truly well known, but it's surmised that people who smoke end up with so much chemical imbalance in their blood that these chemoreceptors are no longer really able to gauge CO2 levels properly. pH levels are always off, so what ends up happening is the last failsafe is the hypoxic drive, which is more of a last gasp, literally last gasp method of breathing, where you're just triggering a breath based on low levels of oxygen. This is the absolute end of backup. Now, we as paramedics, if we're dealing with a patient who is living on the hypoxic drive, like end-stage COPD patient who's really sick, if they're short of breath, they get oxygen. In the pre-hospital setting, the 20 to maybe 30 minutes you're spending with this patient is not going to knock out that hypoxic drive, because theoretically, if you oxygenate somebody whose drive to breathe is based on low levels of oxygen, logically it would make sense that they would stop breathing, and that has shown to be the case, but only after about 24 hours of oxygenation. So regardless of what their drive to breathe is based on, the body still needs oxygen. So giving them a 20 to even 30-minute supply of oxygen with this breathing process in place is not going to cause damage. It's going to feed the cells, which is really our ultimate goal, is to maintain that aerobic metabolism. So when you're thinking about this hypoxic drive, if you're doing a long distance transport, critical care transport, or a fixed wing transport, and you're thinking, all right, this is going to be like maybe a 5 to 6 hour event, you might want to put the hypoxic drive into consideration with your care. But for pre-hospital approach, you really aren't that concerned, because while giving high concentration O2 over time will increase that partial pressure of oxygen, it's going to take much longer than the period of time that you have, that you're spending with your patient. But of course, once you get to the hospital, things change. And as far as nursing goes, this patient would probably have a regulated flow of oxygen, not a free flow like they would get out in the field. Now, in addition to all of these backups to the final hypoxic drive failsafe, we have other variations that can control the ventilation. Fever will increase your oxygen demand and cause increased respirations. Certain medications can increase respirations. Things that affect the central nervous system, amphetamines and these types of stimulants. Pain will increase your respiratory center, emotional state, you can become hyperventilation, and then inversely you can have narcotics, which can actually dull the brain's ability to monitor the blood and cerebrospinal fluid, or receive or interpret messages from the chemoreceptors, which of course will lead to hypoventilation and then cessation of breathing. So there's different things that can bring this on. So you get the air across, and the oxygen is now diffused into the blood on the capillaries. And now they seat on the hemoglobin located in the red blood cells. That's your goal, because if you just have the oxygen make it into the blood plasma, you're not going to be able to deliver it. The only way you're going to get it down to the tissue is if it's carried by hemoglobin in the red blood cell. We use terms like fraction of inspired oxygen. This is what's the percentage of oxygen in inhaled air. So, for example, room air is 21%. We can increase this fraction by giving adjuncts. Like a nasal cannula can bring you up to as high as 44%. A partial rebreather can bring you up to about 70 to 80%, and a non-rebreather is 95 to 100%. So we're able to regulate our FiO2s. We need to actually get oxygen seated on those hemoglobin proteins. Hemoglobin has an affinity for more of something. So if it sees more of something, it will have an affinity for it. It also loses an affinity when it sees less of something. So what does that mean? When the hemoglobin is at the alveoli, when the red blood cells travel to the alveoli, they end up having an affinity for oxygen because they see more oxygen than CO2 in a normal situation. And when you give high concentration oxygen, you increase your FiO2, then they'll actually have a higher affinity. So you'll end up seating more molecules, oxygen molecules, on the hemoglobin. As it makes its way down to the left atria, to the left ventricle, pumps up the aorta down to the great arteries, makes it out to the arterioles, and now it travels into the capillary bed. So whatever capillary bed it made its way down to, the cells down there have used up their oxygen, and they've wasted CO2. So the blood, at that point, there's higher amounts of CO2 in capillary blood at the tissue. What happens then is that hemoglobin loses its affinity for oxygen and releases it into the bloodstream. And it couldn't come at a better time, because then with the process of diffusion, oxygen will carry across the cells. So our goal is to make sure that the hemoglobin is being used to its maximal state, that all four seats are seated with oxygen. Sometimes it might have two, sometimes it might have one. You know, that's not good because you're not maximizing oxygen delivery. And that's why we give supplemental oxygen. So hemoglobin is that protein that transports the oxygen. Without hemoglobin, you cannot make that journey to deliver the oxygen. So the normal values, men have about 14 to 16 gram per deciliter of hemoglobin, women 12 to 14 grams per deciliter. So when they draw on values, that's what they're looking for. Hematocrits are the percentage of red blood cells in whole blood. Normal values about, for the range is between 45 and 52%. Women's a little bit lower. So what I'm just describing is that oxyhemoglobin dissociation curve. This is oxygen saturation. So what we're talking about by saturated oxygen, it's the partial pressures. It's the proportion of oxygen that's dissolved in plasma. And that's what's measured by pulse oximetry. And you can see as the oxygen pressures increase the saturation levels go up. Now the problem with this is in an acidic state where there's more CO2, hemoglobin will readily give up oxygen faster or ignore oxygen. That's in a state of acidosis. In a state of alkalosis, hemoglobin holds on to more oxygen. So think about this. Where do you see an alkalotic state? You'll see more alkalotic states at the alveoli because you're breathing in oxygen. If you're breathing in more oxygen through a non-rebreather or even a nasal cannula, you're doubling the alkalotic state by doubling the oxygen levels. You're going to have a higher affinity for oxygen to be seated on the hemoglobin. Where do you see the more acidotic area? Down by the tissue, because of the CO2 and waste products that are being created by cellular metabolism. And in that environment, the hemoglobin loses its affinity for oxygen and unseats it. Now, respiration is the process of oxygen being used by the cells to create adenosine triphosphate and wasting CO2. In conjunction with sugar molecules, this is known as the Krebs cycle. That exchange of oxygen and CO2 is a vital, necessary part of life. Just because you have adequate ventilation does not mean that you're getting adequate respiration or perfusion. It helps, but it's regulated by those partial pressure, by Henry's law, by Dalton's law, the ability to diffuse the oxygen across. Is there enough space in the container? Are we getting CO2 out? One primary common respiratory disease where this ventilation and perfusion can have an issue is asthma. With asthma, you can breathe in, but you can't breathe out. So what ends up happening is you end up with low levels of CO2 being exhaled, more of it staying in. This is going to disrupt the ability for oxygen to cross over and be seated by the hemoglobin. So it's a structural issue, yes, by the bronchoconstriction. If we correct the structural problem, then we can correct the perfusion problem. But it's a structural problem to correct the exhalation, not the inhalation. Asthmatics can breathe in very easily. So I described this process of internal respiration, this aerobic metabolism. The battery pack of the cell is adenosine triphosphate. Cells have normal function, they are instructed to do other functions, but they have their normal life processes. They're not plugged in anywhere. They have to create energy. And the way they create the energy is using sugar and oxygen. They split sugar molecule into two pyruvic molecules, a substrate of sugar. They dump it into the mitochondria with oxygen, and they undergo that Krebs cycle. They create 32 molecules of ATP, and they off-gas carbon dioxide. This is happening right now, and this is peak energy creation. This process assures good cell health and life. Now, without oxygen, the cells can still go through metabolism, but it's now much less ATP is being produced. Instead of 32 molecules, now it's creating between 2 and 4 molecules of ATP. And by the way, it costs 2 molecules of ATP. It expends that energy just to split the sugar atom molecule into 2 pyruvic acid molecules that can be used by the mitochondria. So you're basically wasting 2 molecules of ATP, and you're creating 2 molecules of ATP by just burning sugar. That's anaerobic metabolism. That's not going to be enough over time to support life. The other problem is that the waste product of anaerobic metabolism is not CO2, it's lactic acid. When you have this lactic acid, now we're talking about not respiratory acidosis by elevated CO2, instead it's metabolic acidosis. The organ that controls the acid-base buffer system of the metabolic system are the kidneys. So the kidneys need to get rid of that excess lactic acid. That takes a little bit longer, creation of urine, but this lactic acid, while it's free-flowing in the blood, can cause severe damage to other cells that are unaffected. So this is more of a gradual process where the organs begin to die and then the organism dies. We talk more about shock. This is where the golden hour really comes into play. Skeletal muscle can go 2, maybe 3 hours in some cases without oxygen, without delivery of oxygen. The reason why is because they actually store oxygen on myoglobin. Right? So they can go a long time. Organs, generally, the liver, pancreas, kidneys, they can go about 45 minutes to 60 minutes without oxygen. The brain can only go 4 minutes without oxygen. But we base the golden hour on organ death. If the cells are denied for an hour, then the organs begin to fail. Lactic acid buildup will speed up that process of cell death. So what is our goal as paramedics? Assuring a good airway and trying to maximize that forced inspiratory oxygen percentage with supplemental oxygen to make sure that we are able to seat 4 molecules of oxygen on every hemoglobin protein. Because this is where we come in. When there's disruption in any of these issues, the ventilation, the oxygenation, or respiration, we've got to recognize it and treat it immediately. That's why it's paramedic, it's up at the top. Without a proper airway, everything else will fall apart. Focus on brain. 4 minutes. That's what we've got. After 10 minutes of hypoxia, brain cells die, and that's irreversible. And that is the definition of hypoxia, the inability for tissues to receive or process oxygen. And there are different signs and symptoms. Early signs will be neurologic. The brain is a little upset. It's the most sensitive organ, and you're going to see signs and symptoms of that sensitivity coming to light. Restlessness, irritability will flip into our sympathetic tone, our fight or flight, right? So it will be tachycardic, anxiety. Late signs, as the brain cells start to die, we'll have a change in mental status. Our respiratory centers will not be monitored anymore. and our cardiovascular system will begin to collapse. So I talked about being able to force air in and then not only getting air into the alveoli, but allowing it to cross over and to be seated on the hemoglobin. This is known as ventilation-perfusion ratio. So we need to have airflow and blood flow. Ventilation and perfusion must be matched. If we're breathing, we need to have blood lining the alveoli in the capillary beds to make this diffusion gas exchange. Without it, we end up with what's known as a mismatch. We're not getting oxygen into the bloodstream for different types of reasons. In a pulmonary embolus, there's no blood flow. In the case of asthma, there's too much CO2 that's being retained because they can't exhale it out. So CO2 is not diffusing across, therefore oxygen is not diffusing into the blood. What ends up happening is this CO2, instead of going out through the alveoli, it's carrying across back to the left atria. It's not supposed to do that. So we need to assure that airway patency is intact and understand maintaining the structure, understanding the bronchioles and the alveoli, how to properly get air down there is important. Now, different things can cause this obstruction. I talked about the intrinsic factor like pulmonary embolus. In addition, you have things like allergic reactions, tongue obstruction. Extrinsic, now we're talking about trauma. An external force, trauma, blunt penetrating trauma to the chest wall that disrupts the ability to have lung expansion. One common injury is a sucking chest wound or a tension pneumothorax. When a patient is hypoventilating, we're producing more carbon dioxide than able to eliminate it. Hypoventilation will lead to acidosis. Hyperventilation, we're blowing out more CO2 than we need to maintain that partial pressure of 35 to 45 torr. That's going to cause alkalosis. You can see the balance on the table 2. As we become more respiratorily acidotic, we end up with more carbonic acid. We retain CO2 in the form of carbonic acid, and that makes us acidotic. This is hypercarbia. In addition to trauma, some other external issues are environmental. High altitude, the percentage of oxygen stays the same, 21%, but the partial pressure drops. So the ability for you to diffuse that 21% decreases. So you need to have better pressurized air. Other things that can happen, toxic gases like carbon monoxide, cyanide will displace oxygen. Helium will displace oxygen. One of the things you find as paramedics now, just came about this year in 2013, people want to kill themselves by inhaling helium. Helium will displace oxygen and not allow it any space in that container. and you'll basically suffocate in a matter of minutes. The problem with this, when we talk about scene safety, is that they're laying in bed with a helium tank turned on in the room. You walking into that room, the toxic gases in that room are going to affect you in a matter of seconds. So recognizing that it exists is paramount to your assessment. That's scene safety. And we have a whole myriad of other things that can affect perfusion of oxygen and get in the way of that diffusion process. Submersion, pulmonary edema, let's say a respiratory burn, chlorine burns that cause pulmonary edema, or these mustard disease, asphyxiants. Patients who are hypoglycemic, their glucose levels drop, but also their oxygen levels will end up dropping as a result. It has a lot to do, glucose levels have a lot to do with that dissociation curve. An infection will increase metabolic needs. We're creating more white blood cells, and these white blood cells need oxygen as well to survive, and they will cause you to have a higher oxygen demand. Other issues like hormonal imbalances, diabetes, buildup of sugar, going into burning of fat instead of sugar with oxygen will create about 28 molecules of ATP, but kick off ketones, and these ketones are acidotic. An issue of shock, you're not perfusing to tissue. As a result, the tissue will flip into anaerobic metabolism and kick off lactic acid, and if denied oxygen for 45 to 60 minutes, the organs begin to fail. Heart conditions can reduce blood flow, congestive heart failure, cardiogenic shock. These all play into effect. And talking about shock, shock by definition is the inability for the cardiovascular system to deliver oxygen to the cells. For whatever reason, we can have obstructive shock, we can have hypovolemic shock. There's different things that can disrupt the ability for oxygen delivery. Everything is to balance out our pH. Has to be between 7.35 and 7.45. That's the gold standard. That's how we survive. If we're too alkalotic, we can have tissue damage. We're too acidotic, the same thing can occur. So we need to maintain that balance. We do it with that respiratory buffer system and the metabolic buffer system. Acidosis can be brought on by a respiratory function if you retain too much CO2. Not only does it if the partial pressure of CO2 increase, it doesn't allow oxygen to enter, it displaces it. But also, where there's too much CO2, you will have too much carbonic acid. And that carbonic acid will make you more acidotic. Inversely, when we have our metabolic system, the lactic acid that's built up as a byproduct of anaerobic metabolism, or the ketones that are acidotic that are built up by burning sugar instead of fat, will make you metabolically acidotic. And the kidneys need to create more urine to get out that excess acid. So, respiratory acidosis, it's the retention of CO2 restricting oxygen from diffusing in. So as your respiration drops, you maintain, your CO2 levels go up. As your CO2 levels go up, there's a shift in your increase in carbonic acid. So this makes you acidotic. With respiratory alkalosis, you increase your breathing, your CO2 levels drop, this leads to a drop in carbonic acid, and you become alkalotic. Metabolic acidosis, what you're looking at is acids that are produced from anaerobic metabolism, like lactic acid. These acids balance out, they consume the bicarbonate ions. Bicarbonate ions drop, you become metabolically acidotic. So we have that compensation in place. The best way to get rid of CO2 is through exhalation. So as we become acidotic from a respiratory perspective, we will breathe faster. That's normal. That could be something at excessive muscle use. During exercise, you will breathe faster. During exercise, you will need to blow off excess CO2. That's a normal trigger. But from the metabolic state, as the metabolic acidosis rises and the pH begins to drop, the brain is going to recognize the drop in pH and immediately try and compensate it by breathing faster. And you see this with trauma patients who suddenly start having tachypnea while they're in a hypoperfused state. This is being triggered by that increase in lactic acid, decrease in bicarbonate ion, and you end up with metabolic acidosis. Really, the best way to get rid of this is to deal with metabolic acidosis is to get rid of it in the urine. So, talking about metabolic systems, the alkalosis, the pH is increased and the CO2 level is normal. So you draw labs and you say, all right, they have a pH, let's say, of 7.5, which is alkalotic. The CO2 level is 37, which is between 35 and 45, so it's normal. What's happening at this point is you have metabolic alkalosis. To understand the acid-base balance, there's an equation called the Henderson-Hasselbalch. And what it says is if you have increased respiration, then you have a drop-off in CO2. If you have decreased respiration, you have an increase in CO2. Okay, so we understand that, because that's the only way you can regulate your levels of CO2 is by inspiration and exhalation. If you have increased levels of CO2, that means that you retain more hydrogen. And since you retain more hydrogen, your pH score goes down. That's a standard. The more hydrogen you have, the lower your pH. If you're down to 2 or 1, that's high acidosis. That's high levels of hydrogen, low pH number. So if you have more CO2, then you will have more hydrogen, and this increase will cause your pH to drop. If you have less CO2, then you have less hydrogen, and your pH will rise, and you'll become more alkalotic. So what that means is if the pH is low, you're acidotic, your respirations are going to increase. And that will be your compensation. If your pH is high, then your respirations will drop. It will compensate. It will retain more CO2. So when we're doing our assessment, we have to focus on not only the patient's ability to control their own airway. Are they able to speak? What's their mental status? we have to look at their labor of breathing, their efforts. Is it adequate for life? Is it adequate for them right now? Are they able to breathe easily? Can they speak in complete sentences? Do they have control of their diaphragm? Do they have good mentation? What are their lung sounds? Are they clear and equal? We need to recognize inadequate breathing. The range is 12 to 20. Breathing rate less than 12 means that they are under. If your respirations are above 20, you are in a state of hyperventilation. One good way to visualize and see if there's good oxygenation to the tissue is to look for that bluish skin or cyanosis. Patients like to be in a position of comfort. The preferred positioning is that tripod position if they're in any distress. Or if they're in a relaxed state, we'll be in a semi-Fowler position. So these are the things you want to look for with inadequate breathing. What's their positioning? Are they having any problems breathing when they lay flat? Pursed lips, retraction, especially with children, sternal retractions, use of the sternocleidomastoid accessory muscles. All these things play into your assessment. So you want to observe the chest for symmetry. You want to feel for any air movement. Note paradoxical movements that's showing that the thorax has lost its integrity. And things like pulsus paradoxus. So what is pulsus paradoxus? It's when the blood pressure systolically drops more than 10 millimeters of mercury during inhalation. You know, this can be found through your invasive, for your transport paramedics, when you do some invasive monitoring. What you're doing is you're taking a blood pressure internally, and if you see a sudden dip when the patient is breathing, then you know that they have pulsus paradoxus. Talk to your patient. Ask the questions. When did it start? Any other symptoms? Did they take anything to assist them? Did it make them feel better? Did it make them feel worse? What medications are they on? Has this happened in the past? Now they have some airway reflex tests you can run. They do what's known as the eyelash reflex. Are they able to keep their eyes closed? Or if they are, that's a sign that they are conscious. If they keep their eyes closed, or can you open them freely? Auscultate. Remember, the chest, the lungs sit pretty high up. The diaphragm comes right about the xiphoid process. So you want to be able to listen to lung fields above that xiphoid process. Normal breath sound should be inspiratory, expiratory, both sounding loud and clear. There's other types we have. We want to listen to the bronchioles. On the trach, you should hear that loud and clear. On the bronchioles, you'll hear inspiratory shorter, expiratory much longer. Bronchovesicular, medium intensity, and then the vesicular, the edges, you should hear more inspiratory than expiratory. And the normal inspiratory-expiratory ratio is 1 to 2. So for every second you breathe in, you breathe out for 2 seconds. Patients who have, like I said, reactive airway disease like asthma or COPD will have prolonged expiratory phases because they got to force the air out. We want to listen for pitch. Is it higher or lower than normal? What's the intensity? It depends on the airflow rate, depends on the consistency of flow, the ability for the patient to be seated properly. All these different things play into effect with pitch. And you can hear abnormal sounds like wheezing, rhonchi, crackles you have during pulmonary edema. They differ from that low-pitched sound of popping that rhonchi. Stridor, mostly heard up by the trachea or tracheobronchial, and then the pleural friction rub, usually associated with pain. pulse oximetry, once again, is measuring that hemoglobin levels and showing that dissociation curve, and the normal levels should be greater than 95. Rule of thumb. But once again, play everything into effect. I mean, if the patient is satting an 88 and they have a history of COPD and they don't look to be in any stress, you don't have to get that up to 95. This may be their normal oxygen saturation level. Also, pulse oximetry can have skewed numbers based on hypoventilation, trauma, even to something as benign as fingernail polish. So just make sure all this is taken into account. Now we have different types of pulse oximetry. We look at different types of hemoglobin. What we're looking for in pulse oximetry is oxyhemoglobin. Okay, now with CO oximetry, this is a percentage of oxygen hemoglobin compared with total hemoglobin. I mean, there's different types of this protein molecule floating around. What we're looking for with a pulse oximeter is the oxyhemoglobin, hemoglobin that's found that can seat oxygen molecules. And one thing to look for when we're testing for peak expiratory flow is we use that flow meter, and this has kind of fallen out of favor pre-hospitally. It can, if someone is actively wheezing, it can cause some serious bronchoconstriction, but it's something that's used in hospital to determine what their peak expiratory flow rates are. It can show that they're having a problem with exhalation. When an arterial blood gas poke is performed and blood is drawn, the lab values that come back are showing the levels of the partial pressure of gases and the pH of the blood. Now what it's looking for is whether this is an acidic state or an alkalotic state. We want to have a normal pH between 7.35 and 7.45. And now, like I said earlier, these are the partial pressures we're looking for. PaO2 of 80 to 100 torr, PaCO2 of 35 to 45 torr, and you want to have O2 sat of 95%. The base should be, the bicarbonate ion should be between 22 and 26, and the base, it's within 2 to 3. All right, so if you see 29 on the bicarbonate level and the pH is 7.5, that's metabolic alkalosis. New technology that's out there is the Untitled CO2. It's not really new so much as it's been performed a lot in hospitals, but now it's out on the ambulance, and we really have to make it part of our overall respiratory assessment. This will determine ventilatory adequacy. Are you getting out your CO2? How much CO2? What's your partial pressure? It will tell you your partial pressure of CO2 and allow for things like confirming advanced airway placement, and in other arenas like shock, seeing if there is any adequate cellular respiration. Because if you see a hypoperfused state where they're creating lactic acid and no CO2, the Untitled CO2 levels will be low. So a capnometer is giving you a number. A capnographer is giving you not only the number, the partial pressure number, but also it shows the actual waveform and shows you the graduation of the forcing out of carbon dioxide. And at the end of the wave, that's the end of the tidal flow, that's your number. This is why we're testing the carbon dioxide levels at the end of the tidal phase, the end of the expiratory cycle. waveform does that. It's going to give you a contour, your baseline level. It's going to show you that rise. And you want to look for things like, for instance, with an asthmatic, the waveform is going to be more sawtooth. It should be a gradual slope, a gradual positive slope. Because as we're beginning the exhalation process, the first air to hit that meter is going to be the air that was breathed in, that residual tidal volume that was left over. So you're going to see less CO2 and more oxygen. As you get rid of that and it goes down from the alveoli, what was down the alveoli is now finally coming up and out. That's the end of the tidal flow. So that's going to be the actual range. And what you're going to see with asthmatics is going to be, instead of a gradual slope, it's going to be a sharp positive slope upwards. And that will show you that they're a tight asthmatic. When you start giving them treatments, you start seeing that slope level off, you know that you're having a positive change. Here's what we're looking at. If you're starting at B, B is when you start the exhalation. You see how the end tidal levels they jump up pretty quickly. Takes a little time for that excess oxygen up at the trachea to get out of the way, and now we're seeing the CO2 levels going up, 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 gradually, gradually, boom. Now with an asthmatic, that gradual rise will be more pronounced, more sharply positive. And then why it drops from D to E so quickly is when you're taking a breath. One quick way to know that you are in the lungs, you're not really interested in an actual number initially, just confirmation of tube placement, is with this colorimetric capnographer. But please take notes that, especially in the instance where you're hyperventilating the patient with a BVM before intubation, there's going to be forced CO2 in the stomach. So if you intubate in the stomach, you will still get a slight colorimetric change. Don't be fooled and think that that's an actual positive confirmation of proper tube placement. You got to give it 30 seconds, because what's going to end up happening is you're going to introduce air into the stomach and you're going to exhale that CO2. You're going to force the CO2 out, and after about 30 seconds, there's not going to be any CO2 left because there's no way to store it there anymore. So you'll see a quick positive change, maybe a slight change. It might go from purple to gray instead of yellow, but you want to just take note that that's not a positive finding. You have to give it about 30 seconds, and then it will shift back to purple, and you'll know that you're in the stomach. So really the best thing to do is immediately go to your waveform if you have it. You want to actually avoid that colorimetric unless that's part of your system's requirements. But if you do use it, just be aware. Because you can see air reaches the lungs only through the trachea, and there's residual air left over every time you breathe. We have natural processes that we can have to maintain an open airway, and positioning is one of them. Unresponsive patients have better airway management when they're on their side in that recovery position, left lateral recumbent. If you need to really manually handle the airway, they are not controlling their airway, they're not breathing, and we need to insert airway adjuncts, including intubation. Of course, we're going to go supine. We use the head tilt chin lift maneuver, of course, when we don't suspect trauma. The jaw thrust maneuver is a trauma maneuver. Suctioning clears the airway and allows for better visualization and prevents aspiration. It should be your next priority after maintaining an open airway. We have all different types of suction equipment. We've seen it before. Onboard, portable. We We have our rigid tip Yankauer suction catheter, and we have our whistle tip French catheter. Remember, suction no more than 15 seconds for adults, 10 seconds for a child, 5 seconds for an infant. Once again, no more than 15 seconds suctioning for an adult, 10 for a child, 5 seconds for an infant. If you're going to use a bag valve mask, this patient's unconscious, unable to control their airway, we need to address that common form of obstruction. So we want to think about using airway adjunct whenever we ventilate. We have our oropharyngeal airways, they come in different sizes. We have our nasopharyngeal airways, and once again, when are they contraindicated? Head or facial trauma. What can cause airway obstruction? Well, we talked about foreign bodies and the tongue, but also laryngeal edema or laryngeal spasm, trauma or any vomiting, aspiration, or a severe allergic anaphylactic reaction. With the tongue, it falls backwards, and the epiglottis sitting right at the base of the tongue covers over the glottic opening. Easily corrected. Foreign bodies, not so easily corrected as the tongue, but we can manage that. Remember our CPR guidelines, we do the abdominal thrust to a conscious victim. When they become unconscious, we begin chest compressions, and we would at that point, from an ALS perspective, visualize the airway, and we may need to remove them with McGill forceps. Laryngeal spasm, it's a spasmodic closure. It occludes the airway completely, and this could be a problem with things like trauma caused by intubation, in addition to drowning. Laryngeal edema, epiglottitis, anaphylaxis, or an inhalation burn can cause that. Rapid recognition and airway management, aggressive airway management control can correct that easily. Crush injuries to the larynx can compromise the airway with the swelling of the connective tissue. Aspiration, of course, vomiting and inhaling can definitely obstruct the airway. Simple suctioning can reduce risk of aspiration. So knowing that there's an airway obstruction, a mild obstruction, the patient's responsive, they can exchange air, they're talking, so assist them by just letting them work, but be prepared to intervene. Severe obstruction, they can't speak. So we want to, of course, do the abdominal thrusts. If the patient becomes unresponsive, do a quick sweep, ventilate. If you're not seeing anything, go in and visualize and try and remove with McGill forceps. There's your abdominal thrust maneuver. And remember, we don't do abdominal thrust to an unconscious patient anymore. We do 30 chest compressions followed by visualization and 2 quick breaths. 15 for 2 rescuers, or if you have an infant child. So if you can't sweep it out, then go in an ALS and try and pull it out with your McGills. Oxygenation, we have to be able to understand that give oxygen, you increase your FiO2 percentage. We control the percentage of oxygen in the inspired air. We know that oxygen is a medical gas. It's stored in specific tanks, and we have regulators that are specific for these tanks, government regulated. That's how we know that the tank that we're using is an oxygen tank, and that's that PASS system. We know that we replace oxygen cylinders when a pressure drops below 200 psi. And using an equation to know your flow rate and the amount of oxygen in the tank, you know how long it can take. There's a cylinder constant, and they have apps that are out there that can do this. Tank pressure in PSI minus 200 PSI, which is the safe residual pressure. All right, remember, 200 is absolute to maintain integrity of the tank. You always have to have it pressurized. You don't want to go to 0. New York State says 500 PSI, you have to change your tank. So to determine the life of a tank, let's say an M cylinder, we have the 2000 max PSI minus the 200 minimum, so that gives you 1800, times the cylinder constant, and for an M tank it's 1.56, and your flow rate is going to be 10 liters. So it's 1800 times 1.56, which is 2808, divided by 10, which is 281 minutes, or 4 hours and 41 minutes. So that's a formula you can write down and review. They also have apps that you can use calculators for that. Liquid oxygen, of course, lasts a lot longer. It's actually oxygen that is compressed by cooling into a liquid form, and it can last for a very, very long time. Good for long distance transports. A lot of patients who have history of COPD or on home oxygen have this liquid oxygen. We have our oxygen regulators. The pressure is at 2000 PSI, but you can regulate the flow. You can reduce it down to as low as 50 PSI. Flow meters allow the oxygen to be adjusted, and there's different types. There's the pressure compensated flow meter, there's the board-on gauge flow meter, which is very common that we find in the hospitals. Non-rebreathers, preferred hospital and pre-hospital oxygen delivery method for patients breathing a rate of 24 or more during your initial exam. So during your primary assessment, you have a patient who's breathing at a rate of 24 or greater, you put them on a non-rebreather until you find out what's going on. The great thing about this is you can take it off. Contraindications to this is if the patient is unable to breathe, if they can't assist in their own breathing, they're not in distress, they're in failure, we take this off of them. It's not effective. They're not being able to create that pressure changes in the chest properly. We're going to have to force air in. Nasal cannulas, you can increase your oxygen levels 24 to 44% oxygen. So it's good for long-term therapy. It's ineffective if the patient is in respiratory distress. Partial rebreathers, much less percentage of oxygen, about 35 to 60 over a non-rebreather. And what makes it different is that the actual one-way valve is missing along the face mask. So the patient is able to breathe, partially rebreathe their own air instead of just breathing 100% oxygen in the bag. Venturi masks can actually use oxygen and ambient air and mix it together, and it's done by different flow meters that are color-coded, and they give different percentages. So you can have 24, 28, 35, 40%. You can regulate exactly the percentage by looking at the color flow meter, which one you're going to use. We have tracheostomy masks, so if the patient's able to breathe effectively with their trach, you can supplement it with blow-by oxygen. There are times when the oxygen needs to be humidified, and we actually have the oxygen humidifiers. They're much better done in the ambulance than brought in. Of course, we do have the ability to give humidified air through a nebulizer without medication. We can just give our saline treatment instead of medicine treatment, and that is, by definition, humidified air. When do patients need ventilatory support? When they can't assist in their own care anymore. When they're in distress, they're using accessory muscles, tripoding, they're doing all that, they're able to assist. These patients can't assist in their own care. They need artificial ventilation. Now there's a problem with positive pressure ventilation. Normal ventilation incorporates the Herring-Brewer reflex to prevent actual rupture of the lung fields through excessive pressure. Positive pressure ventilation is device-driven, manually driven, but it doesn't have the Herring-Brewer reflex, so there's a potential for lung rupture. In addition, with positive pressure ventilation, more air is needed. You have to increase your intrathoracic pressure. And the problem with that, when you're forcing the air in, the intrathoracic pressure is going to increase, and it's not going to fully decrease on exhalation. There's going to be more residual air volume in the lungs that are being manually ventilated, and that's going to have a reduction in blood flow. Because there's going to have problems with blood making it out of the right atria and right ventricle going to the lungs if the lungs are too inflated. And we could end up with a VQ mismatch through excessive positive pressure ventilations. Remember that cardiac output is stroke volume times heart rate. Average cardiac output is 5,600 cc's. If we're pumping out 70 cc's with each beat out of the left ventricle, then we have to have a heart rate of 80 to achieve that number of 5,600 cc's cardiac output. We can get in the way of this cardiac output by reducing the amount of blood being pumped out of the left ventricle. So when we're doing artificial ventilation, we have to be aware of all these things. Filling up the gastric contents, increasing thoracic pressure, reducing blood pressure as a result. So when we're going to do artificial ventilation, there's different methods that we can incorporate. In your arsenal, part of your scope of practice, you have mouth-to-mask technique. You've got the 1, 2, or even 3-person BVM technique, and a manually triggered or old Robert Shaw devices. Bag valve masks give 100% oxygen as long as there's a reservoir attached. An experienced paramedic who knows what the feel of adequate ventilation is will be able to ventilate properly. The total amount of gas in an adult mask is between 1,200 and 1,600 cc's. Okay, that can be a lot. That's sometimes 3 times the amount of normal tidal volume. So if you're forcing this air in 1,600 cc's, you're tripling the amount of tidal volume. You stand a chance of not only having increased thoracic pressures, but possibly popping a lung. So you got to be very careful. Deliver each breath 1 second, periods, just like normal inspiration, at the appropriate rate, and allow for good exhalation to occur. Manually triggered devices. Manually triggered ventilation devices, like with demand valves, give 100% oxygen. You have to be able to have a good airtight seal, but you really can't test for lung compliance unless you, an experienced paramedic, can feel it. But really just looking at chest rise, that's why we do the ventilation. We just want to see chest rise. Don't go anywhere past that, and you can pretty much assure that your pressures are going to be safe. These manually triggered ventilation devices like the Robert Shaw, these are expensive, and there's adapters that fit different masks, and it's a national standard. It's something that will make it easier for you to force the air in instead of just squeezing the bag. You can see the picture of this. The peak flow rate can go up to 40 liters a minute. There's an inspiratory safety release valve that's supposed to kick in if it senses that the lungs have been completely filled and they're in danger of bursting. The backflow pressure will shut off the mask. Our transport ventilators, we have a very small one, like we see pictured, to very advanced ventilators. And what it's doing is automatically stimulating a breath. So the 2 important settings you need to have in a transport ventilator. You need to know the respiratory rate, and it should be in the normal range between 10 to, on the far end, 20 breaths per minute, and know your tidal volumes. And incorporate the 5 to 6 cc's per kilogram, and you'll know your tidal volume. So somebody who is 80 kilos would get 400 cc's of air in a tidal volume, whereas someone who's 100 kilos would get 500. So you would rate your tidal volume flow based on weight. And if you're doing a transfer, it's always good to maintain the levels that were established in the hospital. So mimic those levels on your transport ventilator. Transport ventilators go through a lot of oxygen. So make sure you're doing a transfer, you switch over to onboard oxygen, because looking at that equation, you can last a lot longer on a large H tank than you could a D tank. CPAP is another device that we have that allows for positive pressure. That's patient-driven, it's not automatic. So every time a patient takes a breath, it'll force the air in, and what that does is it allows the capillaries, the alveoli to stay open. It pushes fluid that's been trapped in the capillaries across into, trapped inside the alveoli, It'll force that fluid trapped in the alveoli across into the capillaries and increase our alveolar storage of oxygen, and therefore allow for better oxygenation. So this is delivered through a face mask typically, and is strapped in place. Some patients tend to freak out if they've never experienced it before. One good pointer is just ask them to close their eyes and focus on breathing. Indications for CPAP: they got to be alert, able to follow commands. They have to be showing obvious signs of respiratory distress. And there are certain diseases that are included, including possible submersion issues that can cause this, but based on your regional, local protocols is when you would be allowed to use this. Universally, it's effective for pulmonary edema. Contraindications: patients in respiratory arrest. This is a patient-driven device, so if the patient's not breathing, it's not going to work. Hypoventilation, signs of a pneumo or chest trauma, it can actually increase it. Some systems, active GI bleeding or vomiting, because the mask covers their face, it can cause problems. If they do vomit, they can aspirate. The patient's unable to follow the instructions. They can't breathe. They're no longer able to assist their own care. There's a change in mental status, and guess what? You're going to have to take over ventilations for them. So the CPAP is generally composed of a generator, which makes that force of air, a mask, a circuit, a filter, and a one-way valve. Most of the CPAPs that are out there now are disposable. The ones that are the permanent kind that are adjunct to BiPAP will contain these filters and these generators. So patient exhales against the resistance, and by doing that, by forcing that resistance during exhalation, you pop open the alveoli. Watch for things like gastric distension, and watch for patient anxiety. If there's excessive pressure, it's overinflating the lungs, it's got nowhere else to go but down into the stomach. So there's ways that we can relieve this gastric distension. There's invasive gastric decompression with the GT tube. These are patients who you feel there's interference of your ability to ventilate. There's a drop in blood pressure because of the buildup of air trapped in the gastric region. So you have your nasogastric tube that can be inserted to a conscious patient. It decompresses the stomach, diminishes the pressure, and because it's going through the nasal passages, you're not triggering a gag reflex that can lead to regurgitation. An orogastric tube, these are patients who have facial trauma where nothing passes into the nasal pharynx. Also works better with patients who are unconscious or it doesn't have a gag reflex, so you don't stimulate the regurgitation. Patients who've had their larynx removed, laryngectomies, require tracheotomy, and that is a stoma, an opening directly into the trachea, right past the absapple to cricothyroid membrane. Now there's partial and total laryngectomies. Partials, they're able to move air and speak. They speak usually if they hold over the stoma. They put a finger over the stoma, they can talk. And then you have your total laryngectomies when they speak with a voice box. These patients with total laryngectomies, you cannot intubate them and you cannot have any BLS airway maneuvers involving the oropharynx. When you're ventilating a stoma patient, you don't have to use the head tilt chin lift method. Why? Because the tongue is out of play here. We can do the bag valve mask or blow by oxygen. We have different types of advanced airways, tracheotomy tubes. Place it right into the stoma, and you can ventilate right over it. These are with unconscious patients that you need to have rapid access. These patients will not be intubated. You do not need to insert a tube through the glottic opening. The glottic opening is out of play here, so it's the stoma. Dental appliances like dentures, bridges, they can make for issues with airway management. Just realize that if they're loose, pull it out. If you're doing BLS and you have a patient with dentures, you'd like to keep the dentures in place because it gives you a good form of a jaw that you can ventilate appropriately. You'll have a good tight seal. If you have to intubate a patient with loose dentures, pull the dentures out. Facial trauma, severe swelling, we have to really consider aggressive airway management for these patients. And an early decision is much better than a late decision because you're going to require more advanced maneuvers with a later decision than an earlier one. You can predict a difficult airway by just looking at your patient. Are there issues, right off the bat? Not only just congenital, but there's trauma. Is there, do they have issues with airway management in the past? And then we do the lemon test. We look externally, look at the patient, evaluate, do a Mallampati score, right? Have them stick out their tongue, check for any obstructions, and is their neck supple and mobile? Okay, so the 3-3-2 they mentioned is mouth wide open, more than 3 fingers. The mandible length is 3 fingers or more, and the thyromental distance, the distance from the hyoid bone to the thyroid notch, is 2 fingers wide. That's that's a manageable airway. You're probably going to have a good percentage of glottic opening and be able to pass a tube effectively. Mallampati scores based on the tongue. As you remember, the tongue, a portion of the tongue is the epiglottis, so an enlarged tongue logically will be an enlarged epiglottis that's going to get in the way of the glottic opening. So the bigger the tongue, the bigger the epiglottis, that's going to cause a problem. So patients with big tongues, you might want to think about going with Miller. It's a better way to manipulate that epiglottis. With obstructions, anything that might interfere with visualization, like foreign body, obesity, if they're bleeding, are there masses, all issues that you want to think about. With neck mobility, sniffing is ideal for intubation, so are they able to have good mobility? But if not, are they a trauma patient, are they elderly, and they have issues with kyphosis of the spine and they're forced downward, is there going to be a problem with you visualizing? So endotracheal intubation is that tube passing through the glottic opening, sealed with a cuff. Oral tracheal intubation is through the mouth, nasal tracheal intubation is through the nose. The advantage, of course, it's the gold standard. It's a secure airway. It's going to protect against aspiration. It's a way to administer medications. It's an alternative to IV or IO access. It requires special equipment, though. That's a disadvantage, and it requires adequate training. And it overrides the physiologic functions, like the Herring-Brewer reflex. Complications with it could be a traumatic intubation, bleeding, excessive attempts at intubation to a patient who's apneic can lead to severe hypoxia. There can be swelling caused by improper intubation, vocal cord damage, barotrauma from excessive ventilations, a lot of problems. So you have to be very careful with an intubated patient. So we have our basic structures of an endotracheal tube. Pediatric patients are uncuffed, 2.5 to 4.5. And the ET tube is inserted through the mouth, the trachea, visualizing the glottic opening. Visualization and watching the pass, that's known as primary confirmation. These are the indications for direct laryngoscopy. It's it's always good to position the patient as far back as possible, lifting the tongue away from the back. You have a better plane, we call the pharyngeal plane. You want to be able to visualize this correctly. Look for that glottic opening. Now there's other assist devices that we have. When you have a difficult intubation, when the percentage glottic opening is less than 100%, and you need assistance. And one of them have is something known as a gum elastic bougie. It replaces the endotracheal tube as far as your insertion, your initial insertion. So what will happen is you insert the gum elastic bougie in first into the trachea, and then that serves as a guide wire for the endotracheal tube. So you can see you're inserting the gum elastic bougie. It's a lot easier to manipulate in, and once that's in, it's the guide. And then you put the tube in through it. Then you pull out the bougie, and now you've secured the airway that way. So primary confirmation, once again, visualization. I saw it pass through. I saw it. Then we have our secondary. Auscultation. You want to listen to make sure that it's not in the esophagus, that it's in, that it didn't drop into the right main stem. So you want to hear lung sounds in all fields. Okay, if it does drop into the right main stem, or in some rare case the left main stem, just reposition and re-listen. You should also feel very little resistance when you're squeezing the bag, but that's not always the case. If you have severe anaphylaxis or tissue edema, you can have increased resistance. Other secondary devices, continuous waveform capnography is, of all the other secondary devices, it's the most reliable. Nasal tracheal intubation. An advantage to this, it can be done to a responsive patient. You don't need a laryngoscope, and the mouth is out of play. It's going into the nasal passages. Disadvantage to this, it's actually a blind technique. You really need to have a good, thorough understanding of it and be comfortable using it. And it can cause some bleeding if done improperly. Some endotracheal tubes they make are designed for these blind method tubes. So the technique, the patient has to be breathing. You advance it as the patient inhales. So you insert the tube into the nostril. It's the right or left nostril, it doesn't matter. Manipulate the head to control the tube tip position. Instruct the patient to take a deep breath and gently advance the tube. If you see a soft tissue bulge on either side of the airway, then you probably went to the piriform fossa, either right or left. No tissue bulge, and you don't hear lung sounds, the tube's in the esophagus. Another type of blind intubation is digital intubation. This is where you actually palpate the glottic structures with your fingers and then pass the tube in between the two fingers. This is an extreme airway maneuver, and it should not be done on obviously a conscious patient, anybody who has potential to bite down. So when it's indicated, like I said, extreme conditions. Laryngoscope technique has failed. You're in a confined space and you can't correctly manipulate around to get good visualization or anything else, but it is a last-ditch effort. It should not be your primary attempts. So these are your absolute contraindications. So we have to be very careful when it comes to digital intubation as a last-ditch effort. So these are your techniques. Put it into what we call an open J or a U-handle configuration. All you're trying to do is lift the tongue away, and you're feeling for the epiglottis, and you're going to insert it between your two fingers. Advance the tube towards the epiglottis. Once you feel the cuff pass 2 inches beyond your fingertip, remove the stylet and inflate the cuff. Begin ventilation, and then do your secondary confirmation findings. Remember, with digital intubation, there's no primary confirmation. You do not see the tube pass the cords. Now we have other intubation techniques, transillumination. This is a bright light source that emits, and you can actually see it through the patient's skin. When is this indicated? When your initial techniques have failed. This is another last-ditch effort. It's contraindicated in intact gag reflex or airway obstruction. With pediatric patients, remember the stylet must fit inside the tube. So the device has a bright light source at the end, and this is what you're looking for to confirm that it's going into the trachea. Retrograde intubation, the needle is placed within the trachea through the cricothyroid membrane, but the wire is not going down into the lungs, it's going back up through the glottic opening and out the oropharynx. And this wire is a guide wire for the endotracheal tube. So you feather the endotracheal tube over the guide wire and you guide it back into the trachea, confirm tube placement, remove the guide wire, and you now have airway control. Face-to-face intubation. This is really found a lot in confined space rescue. The paramedic's face at the same level as the patient's face. The head stabilized, the laryngoscope is held in the right hand, the ET tube is held in the left hand. Another way to do face-to-face intubation is if the patient's sitting and unresponsive, not breathing. So instead of going with your left hand, you go in with your right. You insert, pull towards you, and look down. Now, all these are alternate methods of intubation. If you have failed intubation means that you cannot maintain oxygen saturation levels. You have not been able to pass the airway. And failed intubation is not brought on by paramedic failure. Patients fail. Paramedics assist. So you need to recognize early that you're having a problem with a difficult airway and consider alternative airway maneuvers. Don't do a litany of airway maneuvers and go, I'm going to start with endotracheal intubation, then I'll do manual, then I'll do nasal. You got to make a decision on what you're going to do. And using alternate airways is not giving up, it's getting proper ventilation to your patient. So you got to realize that early, that you may need to use an alternate airway, not because of your inability to intubate, but the patient's physical deformities or structural issues that are preventing you to intubate the patient. We've got to recognize that early. Now, if you've intubated and you've got a suction, remember this tracheobronchial suctioning is a sterile technique. And you've got to be able to monitor your cardiac rhythms, because you can actually, if you hit the carina and keep pounding at it while you're suctioning, it can stimulate a vagal response and lower the heart rate. For field extubation, it's a rare procedure. Okay, so before doing it, you may need to do this. You might have a patient, let's say, who was an opioid overdose that was intubated, and you found out after giving Narcan they started waking up, and you have to do an extubation. There may be a standing order for this. It may be a requirement for patient safety, but most field extubations are done through medical control. And remember, when you're pulling out this tube, you might have to re-intubate this patient. So, weigh your options. It's all patient specific. Pediatric endotracheal intubation is a real challenge. And the reason why is children are not designed like adults. They have freakish qualities about them. I mean, if you think about a child, look at South Park, think about Cartman. Big heads, little bodies, stubby little legs and arms. Right, but that big head, that large occiput, and the enlarged openings, glottic openings, can be a real challenge for aggressive advanced airway management. We want to use specialized equipment like thinner pediatric handles. we want to think about straight blades. They're the preferred method over the curved or Macintosh blades. We use the length-based resuscitation tape to determine what size tube and blade we're going to use. It's not like an adult where it's a standard. Children come in all different shapes and sizes, but they're regulated by that resuscitation tape. That's the best way to determine weight and size of a child. Another way to do it, if you don't have your resuscitation tape, you want to find out the right tube size, it's the age in years plus 16 divided by 4. Or it's the age in years divided by 4 plus 4. We want to use uncuffed tubes, and the reason why is that trachea is not fully formed yet. It's almost an hourglass shape. The tracheal rings are not completely solidified around, it's not grown properly. Once your child reaches 8 years, then we have a pretty well-formed trachea that can handle a cuffed tube. The insertion depth should be no more than 3 centimeters beyond the vocal cords. Watch that. They're very prone to go into the right main stem, so you want to maintain that. And since it's not cuffed, there is a real chance of displacement and movement, so you always have to be monitoring your lungs when you're reassessing these patients. Constant reassessment is needed. Pediatric stylettes fit tube sizes 3 to 6. Pre-oxygenate the patient for 2 to 3 minutes. Ensure that their head is in the sniffing position. If you need to, put in an airway adjunct when you're pre-oxygenating to keep the tongue from flipping in the back and reduce gastric distension. Monitor cardiac rhythm, because pediatric intubation can cause bradycardia. For that reason, you may have to administer atropine sulfate. Some systems require it as part of your pre-checklist for intubation. The way you insert the endotracheal, the blade is just like adults. You sweep the tongue to the left, but we don't use teeth and gums to the fulcrum, just like adults. Hold the tube in the right hand, guide it through the vocal cords, record the depth, get your primary confirmation, and then we use a colorimetric end-tidal CO2 detector. But remember, any child weighing less than 15 kilograms, that's 32 pounds, can't use that colorimetric. You go to the waveform. If you visualize the cords and you have the wrong tube size, even though the resuscitation tape told you it was the right tube size, you're going to pull out, reoxygenate, and go with a smaller tube size. If you cannot accomplish intubation after 2 attempts, then you discontinue, and you just stay with basic airway maneuvers. Now we have medications that can assist in our ability to intubate. This is known as pharmacologic-induced intubation, or PII. And this is in place to decrease the comfort, anxiety, make for better airway management. It allows you to be more aggressive. And what we're talking about is sedation. So what we want to do first is knock a patient out, sedate them. We want something that's not going to really affect their blood pressure, because we're going to do airway maneuvers that can actually affect blood pressure with the by disrupting the Herring-Brewer reflex and reducing return of blood to the right atria, that preload. So we want to give a sedative agent that's going to have very little effect on the cardiovascular system. So we think about benzodiazepines like Valium or Versed. You also have butrafenones, which are potent, effective, like Haldol, droperidol. This relieves anxiety. You're not making them stop breathing. It's not something that is, they're going to be conscious, but they're going to be relaxed. Benzos are sedative hypnotics. Okay, so this is something where the patient will not remember the event. They're conscious throughout it, but they won't remember it happening. That's what a hypnotic is all about. Some side effects of the benzodiazepine is respiratory depression, but if your goal is to ventilate and intubate the patient, that's going to be corrected. You have some slight hypotension, and if you ever have severe hypotension, the antidote is flumazenil. It's a benzodiazepine antagonist, but it's very dangerous to give. You don't want to put someone into a benzo withdrawal. Other types of sedatives, hypnotics, we have thiopental or methylhexidol. The issue with this, it causes respiratory depression. Sure, you're going to be intubating anyway, but there could be a problem in blood pressure, and the reason why these aren't really mainstream sedatives you find in a lot of regions is because you can have some irreversible effects to the blood pressure. Now, opioids and narcotics, potent sedative and analgesics, they can cause respiratory and nervous system depression, but they're easily knocked out with Narcan. Other drugs that are out there, etomidate. This is a non-narcotic. It's a hypnotic sedative agent. It's fast-acting and of short duration. So in a setting where you need to knock a patient down quickly and intubate them, you would give this drug. But remember that when you give etomidate, it's short-acting, meaning you're going to intubate the patient, and now they're going to start coming out of it quicker, and they can possibly fight you. So giving this, it should be done in conjunction with another longer-lasting hypnotic sedative, like a benzodiazepine. So you initially give the etomidate, and then you would manage their relaxed state with benzos. So etomidate is very useful for patients with coronary artery disease for these reasons. They don't have histamine release or bronchoconstriction. So patients with increased intracranial pressures or borderline hypotension, hypovolemic, like trauma patients, they would do well with etomidate for airway management. If you have a situation with a patient who is hypoperfusing, right? The brain is the first organ to feel its effects, and it will react with aggressive behavior. It needs oxygen. So when you paralyze the patient, you reduce that anxiety that's outwardly produced by the brain in that hypoxic state. And by doing that, by blocking the musculoskeletal system, right, you end up reducing the demand for oxygen. It's going to assist you in better managing the hypoxia. But realize that these NMBAs, these neuromuscular blocking agents, have no effect on consciousness. Patients can be, they will be conscious and aware that they're paralyzed. And that can be a real horror. So you need to, of course, sedate them first before you paralyze them. Now, just to review the skeletal system, remember you have two nervous systems. You have your voluntary nervous system and you have your involuntary nerve, or your autonomic nervous system. Now the autonomic nervous system is broken down into the sympathetic and parasympathetic, the fight or flight or the feed or breathe, right? And that is regulated by, sympathetic tone is regulated by epi and norepi, and parasympathetic tone is regulated by acetylcholine. Those are the neurotransmitters. So that's the involuntary side. Now the voluntary side is the somatic nervous system. This controls your skeletal muscle. Acetylcholine is a neurotransmitter of this nervous system. It's under conscious control. When acetylcholine releases, it goes across into the target muscle that is voluntarily being requested to work, and it causes sodium channels to open up, and we have muscle contraction. This is known as depolarization. Right? So acetylcholine is responsible for opening up the sodium channels that trigger that twitch of the muscles. When you give a paralytic, you're blocking the acetylcholine receptors on the sodium channels. So the acetylcholine can't work. So what ends up happening is you lose the ability not just for movement, but also pain sensation. So you have a cessation of the somatic nervous system. That's what these NMDAs, or neuromuscular blocking drugs, do. And we have two different classes. We have our depolarizing and our non-depolarizing. There's only one NMDA that actually has a depolarizing quality, and that's succinylcholine. What we mean by depolarization is when the paralytic is given, what it does, its first blocking action is to allow the twitching to occur, to allow the acetylcholine to cause the sodium channels to open, and then the blocking occurs. So it depolarizes and then blocks. So we will have systemic twitching. It starts in the face and the jaw and cascades its way down the body. So when you give succinylcholine, you'll know it's effective because you'll see that depolarization occur, that twitching occur. A cascading twitching down the body. That's when you know that the most important muscle now has been paralyzed, the diaphragm. The patient is not breathing. Make sure that you sedate the patient before you put them through this. It's a horrible process to do conscious. So they need to be sedated, either with etomidate or benzo or another hypnotic, and now you can paralyze them. The succinylcholine is rapid. It only lasts for about 20 minutes. That's enough time for you to intubate. And then you back up the succinylcholine with our non-depolarizing neuromuscular blocking drugs, like vecuronium or pancuronium, rocuronium. These are given weight-based, and they are done more long-term than succinylcholine. So what they're doing again, they're binding to the acetylcholine receptor sites, and when they do that, they will not allow the sodium channels to open on the muscle cells. And that is the sodium rushing in is the beginning of the process of muscular contraction. So it reduces it eliminates the ability to contract, and that's the motor function, but it also reduces the pain stimulus threshold, so the acetylcholine doesn't travel up. So that's the issue. Now these contractions that we feel with depolarization, these are called fasciculations. These happen very, very quickly. Succinylcholine is a short duration of action. The non-depolarizing agents are much longer, but you still need to monitor. They can cause bradycardia. Why? Well, because they have acetylcholine blocking issues, and bradycardia can be a response to that. So when we sedate our patients, we reduce those excessive fasciculations that you'll get with succinylcholine, and you'll also reduce the patient's anxiety to next to nothing because they're unconscious. So once again, these are the non-depolarizing paralytics. Do not give them until you've gotten the airway. So here's the way it should lay out for rapid sequence intubation. For pharmacologically induced intubation, you want to pre-oxygenate your patient, have the IV in place. Okay, you want to give them the sedative so they go to sleep and they relax. Then we give succinylcholine, which will stop It will fasciculate and it will stop the diaphragm from working, and now the patient is paralyzed and unconscious and not breathing. Now we go in, we manage the airway. Intubation is the gold standard. But here's the problem. If you don't have an airway, you've got a paralyzed patient who's not breathing. They're going to be hypoxic. So early recognition of a problem by visualization, the percentage of glottic opening is very low. You may need to do an alternate type of airway insertion. You might have to do retrograde intubation if that's part of your protocol. You might have to use the gum elastic bougie. You got to find that out early. And you do a couple attempts and you can't intubate, you've got to think about alternate airways because you've got to get the patient oxygen. Once that's done and you've assured the airway, then you go to your non-depolarizing neuromuscular blocking agents. So that's the process. It's a smooth, rapid sedation and paralysis that allows for good airway management. So we explain the procedure, reassure the patient, cardiac and pulse oximeter monitoring should be done, IV insertion. Pre-oxygenation is key, okay? If the patient is breathing spontaneously, you don't have to ventilate them, just give them a non-rebreather. If they're hypoventilating, then we're going to assist them. Understand that when you intubate, stimulation of the glottis in adults can cause a tachycardic response that can increase intracranial pressure. So in issues with head trauma, you have to be very careful with this. With children, we're concerned about bradycardia, so we would administer atropine. As soon as the patient's sedated, then we administer the paralytic. We look for signs of adequate paralysis. Now with succinylcholine, you'll see those fasciculations. You'll know it's working. We also have the signs of apnea. The jaw becomes very lax, and the eye reflex, the eyelash reflex is lost. Intubate as carefully as possible. Don't give it more than 30 seconds. After intubation, think about a non-depolarizing agent. If you've already, if your system does not have succinylcholine and you go right away with a non-depolarizing agent, then you really don't have to administer another one. You would just monitor, and they have things like train of 4 monitoring that stimulates the ulnar nerve in the wrist, and you look for the twitch of the thumb. And with train of 4 monitoring, it sends out 4 impulses. If you have no movement, then you've over-medicated. If you have the 1 twitch or 2 twitches, that's normal. 3 twitches of the thumb, they're starting to come out of the paralytic. You should give another bolus. 4 twitches, no paralytics are effective anymore, and we need more aggressive paralytic therapy. So we do that train of 4 monitoring. We don't wait until the patient wakes up and tries to pull out the tube. Now, alternate airways we have, the multi-lumens, these are other blind insertion. These are rescue airways if you can't intubate. We have 2 types. We have the pharyngeal lumen airway and the combi tube. This is an example of the combi tube. This is part of your standard curriculum. It's a testing station for the National Registry examination. When is it indicated? Unresponsive apneic patients with no gag reflex, or whom intubation is not possible. So cardiac arrest, or a patient you've sedated and paralyzed. And you see the contraindications. Also, we talk about size. Only used for patients between 5 feet and 7 feet tall, and age. Nobody under the age of 16 should have a combi tube placed. So we have 2 lumens. It depends on where we blindly inserted the tube. Did it go in the lungs or did it go in the esophagus? LMA, these are patients who, an other alternate airway, you cannot intubate, and they require airway management. It's also used in the hospital for patients who don't require endotracheal intubation. These are patients who are undergoing outpatient surgery. And you can see where this rests, right? It goes into the esophagus, and you have the mask resting right at the glottic opening, and you're forcing air in. What are some indications? Well, it's an alternative to BVM. It's less effective with obese patients. You got to watch patients who have eaten recently. They're high risk for regurgitation. Pregnant patients. And it's ineffective for things like anaphylaxis, patients who require high pulmonary pressure ventilation. So you got to think about regurgitation. It's a major issue, especially pre-hospitally, when you're not sure if the patient's fasted. They probably haven't. And one of the side effects of ventilation is regurgitation. Another device that's accepted is the King LT Airway. This is a single lumen. It has the same qualities and insertion style as a combi tube, but instead of having 2 lumens, it's 1. It's designed to go into the esophagus. It will not go into the trachea, or at least that's what the manufacturer says. And you can see its placement right at the glottic opening is where the holes are, where the air escapes. When you push air through, it goes through those holes into the trachea. There's 2 types. There's the King LTD for adults and children, and then the King LTSD. And you can see the advantage of the King over the combi tube is that it's able to be used for children. It's not set where it's 5 to 7 feet and no younger than 16. When is it indicated? When a rescue airway device is required. You can't intubate, patient requires it. Cardiac arrest. All right, contraindications, gag reflex, absolutely not. But also patients with known esophageal diseases and patients who have possibly ingested a caustic substance don't get this. Complications with a King LT, we can have laryngospasm, trauma from improper insertion technique, pushing it too far in. You can also, by pushing it too far in, not create a vacuum of space right at the glottic opening, and now you're forcing air down the esophagus. Another airway device we have is the Cobra PLA. They say it's a cobra because the edge that inserts in looks like a cobra's head. It's available in 8 different sizes based on patient's age and weight. Now, the gold standard, once again, is intubation. There's different types of intubation. We're using the oral tracheal, you also have nasal tracheal. It's all patient-specific and issue-specific. You want to get that tube. That's your goal. But if you can't get the tube, and you need to get the tube, then you have your rescue devices. You have your King Airway, you have your combi tube, you have your LMA, and you have your Cobra. These are all approved for your agencies, and they're all part of your standard curriculum and scope of practice. If you can't get a rescue airway in, now we got the last ditch effort, which is our surgical airways. Now we have our surgical and non-surgical cricothyrotomies. You have to be comfortable with anatomy and understand where the cricothyroid membrane is. An open cricothyrotomy, you're going to have to incise the cricothyroid membrane, insert an endotracheal tube directly into the subglottic area. The cricothyroid membrane is ideal for a surgical opening of the trach. You have cricothyrotomy kits. They have the modified method now called the Sellinger technique, and these are introducers into the airway. It's more than just inserting a 14-gauge catheter. You need to put a tube in that's going to have good inspiration and exhalation. You need to get rid of that excess CO2. It's hard to do sometimes through a needle. So when is this indicated? The airway cannot be secured through our conventional means, and there are different things that can cause that. Foreign body obstructions that cannot be removed, swelling of the airway like burns or anaphylaxis. Trauma to the maxillofacial area, so you can't orally or nasally intubate. When is it contraindicated? Well, it's a last-ditch effort, so you have to make sure that all of your other efforts have failed before you just jump on this surgical airway. You can't identify landmarks. Do not insert needles or scalpels to areas you can't identify. Crush injuries, and then children under the age of 8 is a national standard of not indicated. Now, if you use a needle cricothyrotomy, it's a 14 to 16 gauge needle, and then you attach something known as a jet insufflator, pictured here, where it forces air in and allows air to come out. So remember that what we want to do as paramedics is manage a patient's airway. If we can assure the airway is patent, then we know that everything else should be able to fall in place, because at least we have an entry point for oxygen. Know that getting oxygen into the cardiovascular system involves having the correct partial pressures together. Henry's law is assured. We have good ventilation-perfusion matching, okay? And many conditions can inhibit this ventilation-perfusion match. So adequate breathing, 12 to 20 breaths a minute. Adequate tidal volume, good inhalation, exhalation. Just talking to your patient will be able to tell you that. Inadequate breathing, now the patient has to use accessory muscles to achieve homeostasis and have good ventilation. Patients with inadequate breathing, we can assist by increasing the FiO2 from 21% to 44 as nasal cannula, or up to 100%. We have the ability to do that. Unrecognized inadequate breathing, however, if we don't see our patients having it, can lead to hypoxia. So we want to recognize that early, part of our primary assessment. We have to maintain patency at all times. In a conscious patient, the way that's done is talking to the patient. If the patient's talking to you, they control their tongue, they control their airway. Okay? But if we have a patient who goes unresponsive, suddenly we have to take over. If a patient fails in their ability to breathe, then we have to take over for them. We do oropharyngeal suctioning to make sure that we clear the airway. We limit it to no more than 15 seconds for adults, 10 seconds for children, 5 seconds for infants. CPAP is new science that's going to assist us with pulmonary edema management by forcing positive pressure back down to the alveoli and getting fluid out of the lungs. Rapid sequence intubation is our ability to sedate and paralyze a patient so we can take total control of the airway. But it is a dangerous procedure, especially if we don't feel comfortable in our ability to intubate, or we have a misconception and say that we have to get the tube. We have to know when to quit and go to a rescue airway if we can't get the tube. It's vital as paramedics that we know that we don't fail as paramedics, patients fail, we assist. We have the ability to intubate. We also have to see that there may be a problem with intubation that's not caused by our issues, our skills, but the patient's physiologic or structural deformity. And if we recognize that early, we'll reduce hypoxia by going in with an alternate airway, like a King or a combi tube, to allow for good airway control and oxygenation. And if all else fails, we have to get that tube, we have to secure that airway, then we think about the surgical end. And we have the types of cricothyrotomy. The needle cricothyrotomy, we have the surgical or open cricothyrotomy. The needle, once again, is done with a 14 to 16 gauge with a jet insufflator, and an open cricothyrotomy is done with a surgical procedure where we take a scalpel, open up, and we insert an actual stoma device.